Ryan Stanton here with ASAP Frontline, joined with a special guest today, Dr. Abdo Khoury. He is the president-elect of the European Society for Emergency Medicine, and interestingly, he's here visiting in Denver for ASAP 19. I met him at one of the receptions that we had, and as somebody mentioned, probably need to get him on the podcast. So that's a great idea, because we're so used to getting prior the international perspective from when at the SMAC conference and other international conferences, with the last two that I went to in Germany as well as Ireland. And it's a fantastic opportunity for us to be able to kind of see the perspective, what we're dealing with from your society's standpoint, and then also maybe some viewpoints of what you see outside looking in of what we're dealing with the U.S. healthcare system. So, Dr. Khoury, thanks for joining me.
Yeah, thanks, Ryan, for the invitation. It's a really honor for me to be here in ASAP meeting, and moreover on the radio of ASAP Radio. So it's give me a real pleasure to be here and to just interact with you and discuss with you the future of emergency medicine, or the actual emergency medicine in the world and in Europe also.
Well, tell me about the makeup of the European Society for Emergency Medicine. How many countries are you involved?
So the European Society for Emergency Medicine, it's a society of societies, of national societies, and so far we have 35 societies, 35 countries in Europe that are member of the European Society for Emergency Medicine, but also we are a society of members. So we have also full members in the society. So we're basically having more than 35,000 affiliate members that are basically and mainly emergency physicians, but also we have paramedics, we have nurses also in our society. Yeah.
So with that in mind, tell us a little bit about some of the landscape challenges and things that you are facing right now from the European aspect of emergency medicine.
Yeah, as you know, emergency medicine in Europe, it's still young as a specialty. Of course, in UK it has been like for 50 years. In Turkey, also in Poland, some years ago. But all over Europe, it's still a new specialty. It was adopted by the European Commission 5 years ago, so it's too early and too young. And we're still facing some challenges because we're still having some countries that do not have the specialty, the emergency medicine as primary specialty. So we are facing this challenge, and we are still struggling with this. But another thing that we are also facing is that we have lots of different systems in Europe, and all the countries do not have the same system in healthcare in general, but also in emergency medicine. And as you know, in France, we have, for example, a really doctor-staffed ambulances that we don't have in UK, we don't have in other countries. But globally, our challenge is to make all these countries more or less having one system to be able to deliver the best care for all our European citizens.
That's interesting, because that was actually going to be my next question, of the big challenge of dealing with more the multinational aspect of emergency medicine, with the various stages that you're talking about, with some very much in their infancy and others very mature specialties. For you as president-elect, as leadership in the college, how do you manage multinational, multiple countries of emergency medicine under one roof?
Yeah, multiple countries, it's something challenging. It can be very difficult to handle, but at the same time, it's something very rich for us, because you have lots of different perspectives that you can put together and just to try to have the one best system. So maybe the French system not the best one, maybe the German system not the best one, maybe UK is not the best one, but when you put them all together and try to give something like a synthesis and something of something better or something best, it can be helpful for society and for Europe in general. So we're working on that, and we've got a curriculum of emergency medicine in Europe. And our curriculum stated really that an emergency physician, after completing his training of 5 years, he'd be able to handle the ambulances, the pre-hospital, the dispatch, the disaster medicine, and in-hospital practice. So it's really a full scope of practices, and this is what we agreed upon in all our European countries. And now we are just moving toward this, applying this curriculum all over.
Well, let's talk about the course. The course of, and it's a super low bar question for you from your standpoint, but from the American listeners, North American listeners as well. What does it take from decision to certified for emergency medicine within the European countries?
Yeah, it's also a tough question because every country has its own rules,
Mm-hmm.
unfortunately. And I just read that, not I just read, I read also that one day one of our philosophers, Victor Hugo, who was very well known in the past century, he stated once that one day he's seeing the United States of America and the United States of Europe looking to each other and working hand in hand.
Mm-hmm.
Of course, you have the United States of America that are united and have one system. Unfortunately, the United States of Europe didn't are not born yet, because we have lots of different systems. It's not the uniform system, and making them all collaborate and work together is a bit difficult. Anyhow, when you are to put all these together, it's quite challenging. But I think that the next generation gonna put this together because we we're having this curriculum actually, and we are trying to apply it on all the countries. So far in the 35 societies that you have, 35 countries that you have, this curriculum, the model of this curriculum is applied in more than 80% of these countries. So fortunately, by the time we're gonna graduate all our residents and completing at least the first year's program, like for example in Denmark, it's still too early. In France, it's still too early. In some other countries, the first generation of residents having completed the complete courses of emergency medicine didn't yet accomplish or finish the training. So within like I think 5 years, we're gonna have lots of residents all over Europe, or lots of doctors all over Europe that have completed this training of 5 years and complete this kind of scope of training, and hopefully they will start to change the system. They will start to uniformize the system.
How does it feel for you to be somebody who is really at the forefront of establishing a kind of generalized system for an entire continent of 35 completely different societies, cultures, many different languages, many different viewpoints on life and everything else? What's it like to know that you're there kind of being there at the very beginning on what in the next 10, 15, 20, 50 years will be probably a very well-oiled emergency medicine system in Europe?
Yeah, it's gonna take time. It's gonna take time. Of course, you said that 10, 15 years, not less. Because saying that it's gonna change all the system within 2, 3 years is completely ridiculous. I told you it's quite challenging. I'm ready to take this challenge. We're working on the curriculum first, and when you start to work on the curriculum and then start to apply the curriculum all over, this is how you can start to change the system. And the system gonna be changed not only by the emergency physicians but also by the governments. And you have to lobby on the governments to make them take the change, which sometimes is not easy. And depending on every country, the challenges are not the same. In some countries, there are a fight between the doctors themselves. In other countries, there's a fight with the government because the government don't want to apply the emergency medicine. So it's gonna take time. We launched the machine to do the renovation, and we hope that we're gonna be able to do things within, let's say, within a decade. I think it's reasonable. Yeah.
And that's to me that's just a huge challenge. The idea of dealing not with one Washington D.C. but 35 Washington D.C.s, and each one quite a bit different. Just seems like a huge challenge in getting kind of everybody at least somewhat on that same page. Transitioning, here in the United States, we're dealing with a ton of stuff with regard to our healthcare system. Questions about the future. Are we insurance payers, single payer, whatever it may be? From outside looking in, where are you seeing the U.S. healthcare system?
Wow, it's a difficult question for me. Basically, in European point of view, most of our countries have healthcare, let's say, dealt on the governmental level. They are not private. There are private insurances, but the essential of healthcare is driven by the government. While in US, it's much more by insurance companies and all that stuff. It's difficult for me to say which system is better. But in my point of view, having a governmental system ensures the quality of care, which is standardized all over the country, and ensures also the care for every citizen on the ground. I don't know what's the case in US. We hear lots of stories about this, that if you cannot afford if you can't afford medicine, you cannot go to emergency department, you cannot go to hospitals. It's something challenging for you and it's something difficult for you. Having it as a governmental system I think, can be because medicine is the right for every citizen, and having it centralized by the government, but there are lots of different way of centralizing this. I think it could be much better for citizens in terms of citizens. For the doctors, it also can be security because they won't be, let's say, on the umbrella of insurances or big lobbies in medicine. So it's once again it's been like this for ages in the United States. I don't know which the way you are taking in the United States. If you want to still ongoing with this kind of system, or you want to try to change it. I'm not sure you're able to change it, but it's taking some kind. When you see it in a foreign point of view, a European point of view, sometimes you're a bit afraid of the system you're going in and the future you're gonna take here in US.
It is. It's one of those things that, here in the United States with the system, the way it's built, there's always been some issues with access. Now, of course, the emergency department has been, unlike many places, especially in other parts of the North and South America, well, mainly South America, there is 24/7, 365 access to anybody, citizen or not, payer or not, ability to pay, intent to pay, to the emergency department. The big issue here from an emergency medicine standpoint is what do we do after? Yeah. And we've actually had a couple of podcasts that we've recorded here on the social determinants of health. And so that those other considerations here in terms of the barriers to health and safety in the United States being what you were talking about, the access to medications, the access to outpatient follow-up appointments and all of those things. And that is one of the big things we have to tackle. And the question is whether the access to emergency medicine, knowing that every person has care, has actually slowed the change and progress of the country with regard to solving that access to care, because many know that you can go to the emergency department. Many policymakers, many leaders know that emergency department is our safety net. And as opposed to being, really that more global solution where we can kind of work people through efficiently. And the other things I see are the utilization of critical care, intensive care units, kind of dedicating so much money to the later years of life as opposed to the other portions of life. I've got a partner who works in my hospital he was in Sweden, and he grew up there, and he was talking about how so much money is focused on the front end, and then as you get older and certain things and certain diagnoses, especially lifestyle choice diagnoses such as smoking and things like that, then you start to have more limitations in symptomatic in-home management, but not as much utilization of inpatient management for those chronic conditions.
Yeah, completely right. I think that many governments see the emergency department as safety net, as you said, but it's completely wrong. Because if you just rely on emergency department to just solve all your healthcare issues, it's completely wrong, and you can have fail completely. I think that government should put more and more effort on prevention, on general practitioners and family doctors, because these are the one who gonna follow up the population and gonna ensure that you have a healthy population. Because when you arrive to the emergency department and then you go to intensive care, all that stuff, you're gonna pay tremendous amount of money, and sometimes it's too late. So prevention should be keynote for any government, and something essential for any government, and the work should be done before the emergency department, and not to make to just see the emergency department as a safety net, and that you can have everything in the emergency department. We are getting overloaded and overcrowded every day in the emergency department, and you're gonna put more and more resources in the emergency department without solving any question and without solving the healthcare issue in all the country, or in your country, in all the continent. And I think that the government should really focus on prevention much more than focusing on the after the emergency department.
And I think it's perfectly fine from the standpoint of having the safety net, but then our advocacy here now is pushing that we need to have the options for where we go from there. So using the analogy of the air traffic control at the airport, you come in here, we make sure that everything's good, stabilization, diagnosis, planning, and then get you to when and where you need to be. It may not be in the department, it may not be in the hospital.
Exactly.
Maybe it's primary care, maybe it's a specialist, maybe it's physical therapy, maybe it's whatever it is, but empowering the emergency department to get people where they need to be, as opposed to the system we have now where it's depending on the emergency department, but without all the back-end processes to take care of those patients once we get them out and disposition. I mean, there's so many areas like that where we have folks that coming in and recurrently to the emergency department just because they don't have safe sources of food.
Yeah.
They can't keep their leg elevated when they've got edema and cellulitis. They can't get their medications. They can't keep their calves dry. You know, there's so many other determinants other than just coming in and diagnosing and using your CT scanner and giving medications to make people feel better.
Yeah, sure. And then also you can work a bit before the emergency department. When you have some kind of pre-hospital emergency medicine that's really strong, not only paramedics, because your paramedics, they go to the patient and they bring him to the nearest hospital or to the hospital. What you do in Europe, basically, we can send sometimes doctors in the ambulances to diagnose the patient and put them in the right pathway. Let's talk about stroke, about myocardial infarction, or things like that. We put them in the right pathways. They pass, they don't go to the emergency department, and they go straight to where they should be taken care of. So, for example, for cath lab immediately, or for stroke units immediately, or things like that. So this is also something you can empower. So it decreases the number of admission in the emergency department, and it increases the quality of care and the survival and decrease the morbidity and mortality also.
And what you're describing there sounds like what is in the infancy relatively here in the U.S., which is the community paramedicine programs, where you have those teams, the paramedics, but also may have PAs, NPs, doctors, whoever it may be, that actually go to the site and actually make visits and do all of these things on scene. You know, I'm an EMS medical director, and I tend to ride along with our community paramedicine team as often as possible, trying to go every Tuesday and go on these runs and see what people are dealing with. And you know, sometimes it's more of a critical care and helping manage with the paramedics that are at their scene, but more often than not, it's trying to establish what's going to be the barriers to this person getting better or staying healthy, and maybe preventing them from having to utilize our emergency services off and on. Where do you see, let's look into the future. You guys just finished your annual meeting, your Congress in Prague.
Yeah.
Where'd you say is next?
Next year, going to be in September in Copenhagen, in Denmark.
So Copenhagen next year. And where do you see look into the crystal ball of European emergency medicine? Where do you see things going for you in the next coming years, and what do you want to accomplish as president?
In the next coming years, what we're discussing actually is to be more and more inclusive in our society. So far, our society was a society of physicians. Now we're opening more and more for nurses, for paramedics that work with us in the pre-hospital setting, in the emergency department. Emergency medicine is teamwork. And so you have to include all these people with you. You're not just doing it as doctors, but you have to include your nurses, your paramedics. And in Copenhagen, we're going to open up for more pre-hospital medicine, for more disaster medicine, for more having paramedics and allied healthcare professionals to come to our conference and to discuss all these issues related to acute emergency care. Not only acute emergency medicine, but acute emergency care also. So we're having more tracks in Copenhagen than we've had in Prague, and more disaster medicine and pre-hospital medicine, which we feel it's essential for Europe.
And where do you see, what are your goals with your presidency? Because you got you're president-elect from Prague to Copenhagen. And then Copenhagen, you become president.
For 2 years, yeah.
For 2 years,
yeah,
okay, so a 2-year term.
Yeah.
What are your goals and kind of big projects you want to see through in the fruition?
Yeah, the big project I'd love to see is to establish emergency medicine all over Europe. And I think that it's going to be very difficult to finish all this during my mandate. It's going to take a bit more time to establish emergency medicine all over Europe. But what we are pushing for is the curriculum, and the curriculum to uniformize the practice of emergency medicine all over Europe. So the curriculum is important for us. It's going to have more people having the same scope of practice all over Europe, and it's something fundamental for us. Yeah, and I hope that I can also increase the number of membership, individual membership in the society, to be able to build a stronger society and bigger society than we have actually.
Interestingly, recently there's been, and even noticing this year more than I think ever, a focus here at ASEP on the international practice, international emergency medicine. How do you see that relationship between the American College of Emergency Physicians, your college, or the European I got the European Society. Yeah. I was like, I didn't remember the U, and I forget.
It's easier for European.
Yeah. European Society for Emergency Medicine. How do you see us working together in strengthening emergency care and emergency access in both countries? I mean, both continents.
Yeah, both continents. Maybe Europe, it's country, big country maybe, but it's not real. Yes, ASAP is one of the biggest societies in emergency medicine. It's most important, and USIM is becoming one of the most important also in the world. Europe is central, Europe is attractive, and everyone wanna come to Europe and to for activities in Europe, because Europe is a really nice place to visit, nice place to be there, and the system, the variety of systems, gives us nice talks and nice discussions on emergency medicine. We're starting our collaboration. Our formal collaboration starts like 1-2 years ago. It's really still young, and as I talked in different meetings I had with the board, with the international section, with everyone, just discussing about collaboration like that, it's very vague. What I'd like to have is to start a collaboration on a single project on something specific, and to be able to deliver some kind of specific things within a time frame, a reasonable and time frame. So that's why we are trying to work on that on the board levels actually, and then we're gonna just elaborate a bigger collaboration. But what we are focusing on, just one project first, or two projects first, and then we'll see how things will gonna go. Emergency medicine between Europe and the United States, there are lots of similarities, lots of differences, and if you can discuss all this, it can be for the advance of emergency medicine.
Well, I can tell you, I love every trip I've gone to Europe. My last soiree for over there was to Germany, Austria, and I absolutely loved it. So Dr. Abdo Khoury, President-elect of the European Society of Emergency Medicine, how can folks get in touch with you if they have questions about your projects and what's going on there in Europe?
Of course, I'm on Twitter, I'm on Facebook, so I'm available anytime. And I'm in you next to Copenhagen to go and broadcast from Copenhagen for ASAP Radio. So you'll be most welcome.
That'd be fantastic. We got to work, since now I'll be here. I'll be on the board for ASAP. I'll have to work with our leadership here on how to make that happen and continue to build those bridges. So we appreciate it, and thanks for making time. I know as we were talking about it last night, trying to make all this happen, get this to happen, and I'm very happy that we were able to make it happen. I'm glad you joined us.
Thanks for the invitation. Thank you so much.
And as for me, you can contact me at youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, or at everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been Some ASAP Frontline.